My name is Ali. I just wanted to share with you this very interesting ECG, which was taken from Dr. Smith ECG blog. He allows the free redistribution of his materials, but he does not endorse the content in this video. So, just to start, this patient is a 50-year-old woman presented with substernal chest pain radiating to her left axilla. An ECG was done on the patient, and the ECG machine showed that this patient had acute pericarditis. So the machine diagnosed it at acute pericarditis. If you look at the ECG, you can appreciate there is diffuse ST elevation in the precordial leads and the lateral leads, as well as the inferior leads 2, 3, and AVF. And there are no reciprocal ST depression, apart from the AVR and VR, which you can have in cases of pericarditis. So, this is a textbook ECG of pericarditis, but would you really call this diagnose this as pericarditis? So, first of all, you need to be very careful when you diagnose pericarditis, because in such cases, when a patient have numerous cardiovascular risk factors presented with typical typical chest pain, the first thing you need to think about is myocardial infarction. You need to exclude it, and the other thing, you need to do serial EKG just to observe for any evolutions of the ST segments as well as T wave, and also probably you need to do high sensitivity troponin to assess any injury, as well as if you are experienced provider, you need to do bedside echo just to assess any regional wall motion abnormalities. So there's a pattern observed by Dr. Smith. It wasn't approved by studies, but it was just observed pattern. So if you look at V3 and V4, you can appreciate there's T wave, there's ST elevation. There's R wave and there's ST elevation in both leads, V3 and V4. The R wave is coming down, but it's not reaching baseline. There's no S wave, and there's no Osborne wave, or what we call it J wave. So let me draw this for you. So for example, here P wave, R wave, and usually have a little wave after the R wave. We call it, this is the J wave or Osborne wave, and then this T wave. So if you have ST segment elevation, if you don't have J wave and S wave, this we call it as terminal QRS distortion, observed by Dr. Smith to be highly specific for acute LID occlusion. So an angiogram was done on this patient and showed that this patient has complete acute LID occlusion. So in cases where you have LID occlusion, you might expect there's ST elevation in the anterior leads as well as the lateral leads, because as you know, the lateral leads are supplied from the diagonal branches of the left anterior descending artery. But what's happening here? Why are we having 2, 3 AVF? This is a pattern of injury of inferior myocardial infarction. Actually, the angiogram showed that this patient had a type of LID called wraparound LID, where the left anterior descending artery supplies the anterior wall of the left ventricle. It wraps around the apex of the heart and supply the inferior wall of the heart, and that's why we're having inferior wall injury pattern 2, 3, and AVF. In 99% of cases of T3 and AVF myocardial infarction, we observe ST segment depression in AVL. So why we don't have any ST segment depression in this case? So AVL is considered a high lateral lead, which is also affected by the injury in the lateral wall, as well as the reciprocal changes from the inferior leads, especially 3. So these competing forces between the ST segment elevation and the reciprocal ST depression bring the ST segment to baseline. Okay, thank you very much.